आसानी है तो
खुश।
तो सर हम लोग स्टार्ट करेंगे बिल्कुल बेसिक से, और आई विल कीप आई हैव अ वेरी स्मॉल स्लाइड। आई हैव अ वेरी स्मॉल स्लाइड। अच्छा सर, आपको स्क्रीन पे नजर आ रही है एनाटमी ऑफ हर्निया?
Anatomy of flap hernia. Yes, I can see.
ठीक है। सर इसके ऊपर जो है ना, मैं अब ये स्लाइड शेयर करने लगा हूँ। जस्ट गिव मी अ मिनट। जी सर। सर ये बेसिक पे हम जाएंगे। मायोपेक्टिनियल ओरिफिस ऑफ फुशार्ड। ये जो है बैक साइड से जब हम स्कोप अंदर डालते हैं तब हमें नजर आता है, और इट्स वेरी डिफरेंट फ्रॉम द ओपन अप्रोच, जिस तरह ओपन अप्रोच के अंदर हमें सब कुछ नजर आता है। आवाज आ रही है सर मेरी?
जी जी बिल्कुल क्लियर।
हाँ। तो इसकी हर्निया की एनाटमी समझनी डिफिकल्ट होती है, सो आई जस्ट बहुत इसकी डिटेल में नहीं जाऊंगा। हमें सिर्फ ये चीज याद रखनी है कि हमारे मेन लैंडमार्क्स कौन से हैं, और लेकिन जब हम स्कोप डालते हैं तो हमें डायरेक्ट हर्निया और इनडायरेक्ट हर्निया का फर्क कैसे पता लगेगा। आफ्टर क्विक रिव्यू, हम लोग जब सिर्फ देखते हैं तो हमारा जो एपिगैस्ट्रिक वेसल्स हैं वो हमारा लैंडमार्क यूजुअली होती हैं बिटवीन द इनडायरेक्ट और डायरेक्ट हर्निया। वो तमाम चीजें जो एपिगैस्ट्रिक हर्निया वेसल से अंदर वाली साइड पर हैं वो डायरेक्ट हर्निया कहलाती हैं। जो बाहर वाली साइड पे जो डीप रिंग से आ रहा होता है वो इनडायरेक्ट हर्निया होता है। इसके अलावा हमारे ट्रायंगल ऑफ पेन और डूम, उसका हमने ख्याल रखना होता है। बेसिकली ये जो हमारा इलियोप्यूबिक ट्रैक्ट है, लेप्रोस्कोप हम डालते हैं नजर नहीं आता, लेकिन हम इमेजिन इसको कर लेते हैं। तो ये टिप ऑफ डीप रिंग और इंगाल लिगामेंट की पोस्टीरियर साइड पर होता है। तो उसके हिसाब से हमने ट्रायंगल ऑफ पेन और ट्रायंगल ऑफ डूम का ध्यान रखना होता है। वो प्रीटी मच सब लोग इससे वाकिफ हैं। तो इससे मैं आगे मजीद चलूँ तो ये पोर्ट पोजीशंस हैं जो कि यूजुअली हम यूज करते हैं। पोर्ट पोजीशंस के बारे में मुख्तलिफ लोगों की मुख्तलिफ राय है, लेकिन व्हाट आई यूजुअली यूज, जो अपने एक्सपीरियंस में मैंने पाया है कि सुप्रा अम्लाइकल में कैमरा डालता हूँ, बिल्कुल अम्लाइकस के पास नहीं डालता। अम्लाइकस को इतना क्लीन पर्सनली तौर पे मैं समझता नहीं हूँ। दूसरा जो फेशियल क्लोजिंग जो है ना, वो अम्लाइकस के बिल्कुल पास थोड़ी डिफिकल्ट हो जाती है, और हमें चूंकि सूचरिंग करनी होती है तो इट्स इजियर फॉर अस कि कैमरा थोड़ा पीछे हो ताकि हम सूचरिंग आसानी के साथ कर सकें। जो राइट और लेफ्ट पोर्ट्स हैं वो मिड क्लेविकुलर लाइन के अंदर हम डालते हैं, और राइट साइड पे हर्निया हो तो जो राइट पोर्ट है वो ऊपर हो जाएगी 2 सेंटीमीटर अम्लाइकस से, लेफ्ट नीचे हो जाएगी। अगर लेफ्ट साइड पे हर्निया हो तो सेम इस तरह ही होगा, लेफ्ट पोर्ट ऊपर हो जाएगी 2 सेंटीमीटर और राइट पोर्ट नीचे हो जाएगी। अब ये राइट हर्निया के लिए ये अल्टरनेटिव पोजीशंस हैं, लेकिन ये टेप में यूजुअली इस्तेमाल होती हैं। सो स्टार्टिंग विद माय फर्स्ट वीडियो। इस वीडियो के अंदर मैं जस्ट ये एक्सप्लेन करूंगा कि पेशेंट की पोजीशन क्या होनी चाहिए, और इसके अंदर जो हमें चीज़ याद रखनी है कि हमारा जो है ना टेबल फुल पेशेंट की डाउन हो, और पेशेंट का जो हेड है ना आफ्टर एनेस्थीसिया वो बिल्कुल बेड के एज के ऊपर हो, क्योंकि आपने हेड साइड पे खड़े होने और आपकी बॉडी को टच कर रहा हो।
Dr.
अगर ऐसा
Shehryar,
मान
Dr. Shehryar, excuse me, I interrupt. So we have a candidate from Nairobi. They are requesting in English. Moses.
ओके सर, ओके
Sorry.
ओके सर। सर जस्ट वन सेकेंड। अस्सलाम वालेकुम सर, कैन यू सी मी? अच्छा सर। सर हमारा जो है ना ये
So we have some candidates, foreign candidates.
okay sir. So I'll be explaining it, the port positions here. When I start the surgery, I droop down my shoulders and I put my hands over the abdomen. Where my hands are coming in a very easy formation, there I will put my ports. So that's my position. And when I'm standing there, I will just droop down on my shoulders. I will extend my elbows so that my shoulders, my neck, they are all relaxed. And where I can put my hands, I aim my trocars there. Usually for the right-sided hernia, it's 2 centimeter above the umbilicus on the right side and 2 centimeter below the umbilicus on the left side. Same alternative will go for the left-sided hernia. So if it's a bilateral hernia, I will put both the trapdoors of the right and left side 2 centimeter above the level of umbilicus. So that's how I'm putting the. This is the aim for the right hernia. I have to go for the right hernia. And that's for the left hernia. So we will start with the case of a right-sided direct hernia. Yes, I've kept the speed of this surgery at 1x, and we'll show you how to raise a flap. Now, what I have to add here, the first step we are going to do is to mark a horizontal line just 2 centimeter above the anterior superior iliac spine. Now we know that the upper edge of the triangle of pain is below the iliopubic tract. So we have to stay at least 2 centimeter above the anterior superior iliac spine in tacking the mesh so that we do not trap any nerve or cause any inguinodynamium. So after marking it, I have started making a flap. I am using cautery only. I do not usually use scissors because I find cautery more easily maneuverable. What I'm doing is I'm using the cautery just to cut the peritoneum, nothing else. Because when we go behind the rectus, I mean the level which I have just read in the video, we can cut the transversalis fascia. We should avoid cutting the transversalis fascia. Now, this is the very bloodless plane that we can achieve. When transversalis fascia has been pushed away, and you can see the transverse fibers of the transversalis fascia, it will zoom in so. That's why it's called transversalis fascia. These are transverse fibers. These should be visible. They should not be cut with the flap. The flap should be very thin. And we can use it with a cautery. On the lateral side, we have to make the space of bog gross, and we will keep the flap very thin, and we will push all the fat away towards the nerves so that the nerves are covered. As long as we keep on doing that, there will never be any inguinodynamia with the patient. Now, what we are going to do? So when I will go for the medial side for the space of red ZS, I have to keep in mind the medial umbilical ligament. These are the medial umbilical ligaments, the red ones. And I will make a cut a bit vertical to them so that my flap is eased up, so that I can easily enter the space of red ZS. Now, as long as you keep on giving a very strong traction on the left hand at 6 o'clock position, this dissection with L-hook is very easy. You have to have a very strong traction from the left hand. You cannot lax it. So the plane will automatically start appearing. A plane will appear between the abdominal wall and the bladder at the medial side. Now it's a direct hernia, so hernia is a bit towards the medial side, and we have to clear it completely so that we can completely open the space of red ZS. You can hear me, sir?
Dr. Shehryar, we can hear you. Everything is clear.
Just a minute, sir.
Yeah, everything is clear and excellent.
Oh, okay, sir. So when I enter the space of red ZS, I can use blunt dissection also, and I will move my shaft of the L hook between the bladder that is on the left side in the video and between the abdominal wall, that is the rectus muscle on the interior right side. I can use the cautery, but I will always give a very good traction from my left hand. See, when I give it the traction, the plane automatically starts appearing. And even with the blunt dissection, this plane is completely bloodless. Now you have to make a difference here, because you can see the fat on the anterior abdominal wall, it is yellow in color, the fat around which I'm working, and the fat over the bladder on the left side, it's in orangish color. So we have to make a plane between these two fats. Do not go in front of the yellow fat, because you will ending up in a bleeding plane. That yellow fat is of the abdominal wall, and the left side fat is the bladder. So we are going to make a plane between these, and it is a bloodless plane. We have to leave a little rim of tissue on the little thin fascia on the pubic bone, because there are vessels on the pubic bone. If we injure them, there will be bleeding. So I keep on using the shaft of the cautery. I'm using it bluntly and repeated slow maneuvers. These are the very slow, same maneuvers. I'm making a cleavage plane between the bladder and the wall. and the space of radius is automatically opening up. If there are small bleeders, I will just buzz them. This patient has a bilateral hernia. So on the left side thing you're seeing is the hernia on the left side also. And if we are doing the bilateral hernia, we do not completely transect the peritoneum. We do a tap on the right side, we do a tap on the left side. The bladder peritoneum, attaching it towards the between the medial umbilical ligaments, it remains intact. So I'm going towards the lateral aspect, and here you can also see it's very easy to make a space of Bogros. Just keep your left hand stretched at 6 o'clock position downwards and use your cautery. I burn and swipe. I just burn it and then swipe with my cautery. I burn it and swipe. So my every movement that you can see here is I'll make a burn and then I'll swipe with the heel of the cautery. Now I'm coming a bit towards the lateral side. And here I will keep on pushing away all the fat and the other tissue towards the nerves so that they keep on covering the nerves. As long as the nerves are covered with these, the gynodynia is very minimal. So after doing a bit of the Bogras, I do not make complete Bogras at the start because I believe that I can get the better plane after dissecting the testicular arteries, which I will show later. I'll go toward the sac. Now this sac is a medial sac. It's a direct hernia. So it is occupying part of the space of radius. And this is the transversalis fascia, also called a pseudo-sac that I'm pushing it away, this white thing. It is a pseudo-sac. We should not pull it. We should push it away. It's pseudo-sac. It's not a real sac. So, and we need to completely push it away. Otherwise, the hernia surgery will not be completed. Patient will have the symptoms. Now, as long as this direct hernia is not reduced, the area of corona mortis, the circle of death, is not exposed. So we have to do it. And if there is any bleeding, we can just grab it and wait for it to just settle on its own. I do not use any ligashore energy or energy device in it because I find them to be unclean. They are not completely autoclave. They are not autoclavable, so I do not use them here. I only use L-hook and autoclaved instruments, no gauze, no washing, nothing whatsoever. So now the direct hernia is reduced and we can see the pubic bone over the corona mortis area also. So this is the area from where the bladder goes inside the direct hernia. We have just dissected it, and the movements, my movements of right hand here are between the pubic bone and the bladder. This is the cleavage plane. This is the dangerous area. The external iliac is just on the right side of my cautery. It's just covered with a thin layer of fat. So my dissection area that I had to reach, the dissection limit is the obturator nerve and vein. They lie at the lower edge of the pubic arch. You can see them. I always reach them, and there I complete my dissection. The white one is obturator nerve. The blue one is obturator vein. There was a little bleeding, so I cauterized it. So after doing that, now I'm making a bit of Bogras. And I will keep on pushing all the tissue away. Now, the thing is that if we directly go into the Bogras at first, at the end of the hernia, we find out that there is still some tissue that we can push away. There's still some tissue we can push away. So I do not go into Bogras directly. I dissect the testicular vessel. When I've dissected it, I enter in a pocket from which, with a single swipe, I can just clearly enter the space of Bogras. I'll show it later. So this is a triangle of doom. This is the external iliac vessel, which is pulsating, and it's a thin tissue over it, and we are dissecting it off. This is the vase on the left side, the white one. And I use monopolar cautery to dissect the vase. I usually avoid doing blunt dissection because it has vascular adhesion. They start bleeding a lot. Now, since the time I started using cautery only, the seromas, the pain, the testicular pain, they have totally vanished away. But I believe that a lot of manipulation of vase and testicular vessels, they cause a bit of testicular pain in post-operative patients. So we have to avoid their manipulation, and we should use the most bloodless possible means. Now, this is the peritoneal flap that I'm taking off the vase. We have to completely take it off the vase till the vase goes inside the seminal vesicle. And the cue to that would be the vase turns towards the medial side. Now, this is the tissue. the tissue that is near the bladder and the previously reduced hernia. We have to take it off the vas. These are the testicular vessels. This is the external iliac. Testicular vessels are the one on the right side. I have to take this peritoneum completely off them. Now, this step is the most critical step. This is the most important step. If we do not take this peritoneum off, our mesh will roll and there will be a recurrence. As long as you completely do this stop, there will never be a recurrence in the hernia. You have to make sure that you have completely taken it off. Now, when you take off this peritoneal flap, the cue is the testicular vessels, they broaden up in a wedge. And you can find where the testicular vessels are because there is a bit of fat with them. Every vessel has its own lymphatics, it has its own fat with it. So testicular vessels can be identified with the bundle of fat with it. And this is the pocket I was talking about. Oh, sorry, this surgery got completed. Sir, any questions so far?
Excellent. Shehryar at the end. So we have some question, especially regarding dissection and use of instrument, definite, but please continue. Shehryar, can you hear me? We cannot see you. Dr. Shehryar. I think there is a loss of connection with Dr. Shehryar. So you can see, so this was a great message from Dr. Shehryar. First, if I conclude till this time, so ergonomics is very important. Your patient position is very important. These are the basics, and then trocar site. So this is very important. So if you see patient in such a situation, patient is head down and tilt to opposite side. If you are doing a right side, then your patient must be left side, tilt to left side, head down, tilt to left side. This anatomical, always fix your patient with your table, because these are key points. Because unfortunately at initial stages, I faced such a situation when your patient is not fixed properly. And also when you will change the position, head down, and so slipping again, you struggle with, so what you would do. So first, these are key points. Maybe for you, this is not important. If the sac, hernial sac size is larger, and if there is bilateral inguinal hernia, always put polycatheter before going to start, because sometime maybe, and also before going to hernia, always appreciate your patient. Okay, Shehryar, please.
Yes, yes, sir. Sir, you were giving a very, very important message. The thing is that you have, when we have to tilt the patient down, the head side has to be down so that the small bowel comes out of it. For that to happen, we have to strap the patient. Now, the thing is that once we have strapped the patient, and it has happened to me a lot of time, I've gone to the table, and the patient's head was not, the level of scalp of the patient was not at the superior most part of the table. So I had to bend over, I had to be like this, I had to bend it like this to reach the hernial area. So you have to make sure that the patient's head should be touching your tummy. You have to tell your OT staff and anesthetist that that's the position, because once the patient is painted, draped, and he's strapped, you cannot change it. Only your back will hurt even more. Now, the second thing is that the side that we have to do the hernia, it has to be 15 degrees up on the tilted side. And I totally agree with what Dr. Imran Abbas just said. You have to pass a Foley's catheter, or at least ask the patient to void himself before a simple hernia surgery. But in a recurrent hernia, or in a bilateral hernia, or in a large hernia, always put a catheter and keep that catheter in place for 24 hours. Because there is a lot of bladder manipulation in those cases. Let me share my screen once more. So, sir, any questions so far?
So please continue, Dr. Shehryar. And
yes, sir.
Then,
sir, I will be focusing more on showing the videos of the tab dissection here and the flap dissection, not the mesh placement. So there is another video here. I've just made an incision over the peritoneum, and the area I use is I make a horizontal incision 2 centimeter above the anterior spherical spine. Now, why 2 centimeter above? Because I want to stay away from triangle of pain, from nerves and everything. And whenever I'm suturing the mesh to the abdominal wall, I again always palpate the anterior spherical spine, and I make sure I am at least more than 2 centimeter away from it. And it also helps me to put a larger mesh. The mesh we use is 15 centimeter from in a longitudinal length, and vertical length is 12 centimeter or sometimes 13 centimeter. So a bigger flap always helps us. And in order to make a bigger flap, we just put the camera port like 3 centimeter above the umbilicus. So again, what I'm trying to demonstrate here is how to make a bloodless flap. And for this, we have to stay right next to peritoneum. Now, a lot of teaching is that we have to remain between the two fascias of transversalis fascia. I humbly disagree with that, because going through the transversalis fascia at any level is going to put you into a bleeding plane. So when you are making the dissection, the rectus muscle, at least in the superior part, should not be visible. It should be covered with the fascia. The inferior epigastric vessels should not be exposed. They should always be covered with the fascia. Like I will show it here. Now, this is the peritoneum. I'm pulling the peritoneum. It's a single cell layer. It's very thin. It's bluish. You can see almost across it. So it should be a thin flap, and the transversalis fascia is there. It's a thick one. And I intentionally made a little breach here to show that these are the inferior epigastric vessels on the left upper side. I made a breach in the transversalis fascia. We should not make such breaches. We should just dissect like this, a good stretch by the left hand on the peritoneum, and a gentle use of cautery will give you the plane automatically. It will just get itself pushed away. The whole principle of TAP hernia surgery is separating the transversalis fascia from peritoneum. There's nothing else. Every time you just have to separate transversalis fascia from peritoneum. So if you can appreciate, if you remain below the transversalis fascia, that is between peritoneum and transversalis fascia, it's a bloodless plane. But if you go above the transversalis fascia, there are vessels there, there's fat there, and it's going to bleed a lot, and the whole screen will become all red. Good thing about TAP, you can always keep on check how far away you are, and this is the medial umbilical ligament. Now, this is the indirect hernia, so medial umbilical ligament is so visible. Whenever you put a scope in, it is the medial umbilical ligament that is most visible, but in the direct hernias, it's not so visible. So it is one of the key points in direct hernia that you might not even find it very prominent at all. So I make an incision vertical to the medial umbilical ligament. It makes my left hand easy. See, the flap is opening up. It's very easy to go inside the space of radius now. So now I'm going into the space of radius, and the space is automatically opening up. And you can see I cannot see the rectus muscle on the anterior side because it's still covered with the fascia transversalis. It is an indirect hernia. So once we have completely dissected the space of radius, that would be all. We'll have to just go focus on the hernia. So, sir, this is the same case we are doing. We are making a space of radius. Now, the problem that people usually face is there is a fear of making a space of radius because there are so many dangerous structures there. There's a corona mortis and everything. So what we have to do, we have to keep giving a good stretch on the peritoneum, and we'll use a very gentle amount of cautery, and it will just open up the plane for us. So this is the video at 3 times the speed, and here again, we are going to separate the yellow fat from the orange tissue. The orange tissue on the left is the bladder. We stay close to the bladder. This is the pubis bone that's becoming visible. So on the lateral side, we'll have to make a thin flap, because if the flap becomes thicker, there will be bleeding there. So when I make a thin flap and stay close to the peritoneum, I enter into a very avascular space. This is the work on the space of Bogros. One more thing, half of the patients, they have a thicker peritoneum than the other half. So you cannot use the heel of the cautery on them. So you have to use the tip of the cautery. So you need a good traction on the left hand and use the tip of the cautery to dissect it off. It takes a bit of time to master it, but eventually you get used to it. These were the hernia contents that were reduced. So we are dissecting around the hernia. It's an indirect hernia. It's a deep ring that we have dissected. You can see, you can appreciate it is a deep ring that we have dissected. And these are the fibers. The fibers you can see near on the left side of the tip of my cautery. These are the Worling fibers. They come from the transversalis fascia and they hook upon the hernia. They will keep on pulling the hernia back into the scrotum. Now you have to keep on fighting with these fibers. As long as you do not divide these fibers, the hernia will keep on, the sac will keep on going away towards the scrotum, and you will have a difficult time fighting it. So gently, with a sharp and blunt dissection, you have to take these fibers off. See, I make a stretch from a left hand instrument. The direction of left hand instrument is towards me and 6 o'clock position, down and towards me. And I keep on moving it all around so that my cautery can make a move. This is the triangle of doom, the testicular vessel, and the vase is invisible. On the right side, the testicular vessel, left side is the vase. So I take a thick bite. I have a strong instrument in my left hand, and I stay very close to the peritoneum. Again, when I have to find the testicular vessels, I just go a bit left to the hernia, and I will always find them, because the shape of the vessel, small vessels start changing. They become wavy, and there is a bit of fat that is going along the direction of testicular vessels. I can just grab it away. That is a nerve. That is a nerve visible in thin limb patients on the right side. Now, I separate, I make a plane between the testicular vessels and the sac using a cautery. I do not bluntly push them away. So I do not just use the blunt dissection, because I fear there will be bleeding and that will obscure my vision. So I burn and swipe. I use my left hand to give me a very good traction. Then I make a burn and then I swipe it away. So you can appreciate that there will be a bloodless dissection. There is no testicular pain after that. Seroma chances are very low after that. One thing you have to remember, the area we are working, it is just near to the external iliac vessels. So my left hand has to keep on pulling the tissue away from the iliacs at all times. And in the case of indirect hernia like this one, I have to dissect the testicular vessel and vase from the sac. Now I usually go only from the lateral side. I approach this testicular vessel from the lateral side and keep on dissecting, and I just see the vase here. The sac is gone on the medial side. So it is again in the 3 times speed. You can see the vase and the testicular vessel, I hope. This is the testicular vessel. I have dissected it away from the sac, and while dissecting the away, I keep on going behind the sac till I see the vase difference. And then I will make my critical view of safety. That's what I used to call it. That there will be 2 structures, the vase and the vessel. They will be completely separated from the sac, and then I will divide the sac. So I'm making our own critical view of safety here. I will just keep on burning and swiping. And the key here is that when the testicular vessel and the vase, they become a bit spirally, it means they have been well dissected away. So this is a testicular vessel. I'm just pushing it away and burning it away, and I'm making sure I take it, dissect away maximally deep into as much into the deep ring as I can. Now I have made a space all around the sac, and I still keep on thinning the sac, and I want to divide my sac as far away as possible. I don't want to divide it near to the flap. I want to go as much into the deep ring. I want to take maximum amount of flap. Now, there was an old teaching. There has been still being taught that we have to cut the flap and we have to leave it and everything. Yes, we can do it. But if you can take out the sac, take out completely, there will be less post-op complications. And there was a paper shared by Majid Chaudhary Saab in the district surgeons group also. It was a recent paper that also agreed with that. We have to take out the complete sac if we can. And if we cannot, then take out the maximum amount of the sac because it will reduce the chances of seroma formation. So here we are. I sometimes use the blunt dissection at the end, and maybe when I'm a bit tired. So my left hand is again stretching it, and I will cut the sac off. And the good dissection means it will just go away into the deep ring. So I've everted the sac, and I will start dissecting a little bit of space of Bog-Ross, and then I will go directly to testicular vessel. Now, here is the thing about testicular vessels. When again, I'll say I'll dissect them, I'll make a pocket, and the key to my dissection is that testicular vessels will start getting broader and broader like a wedge. There will be fat around it, and I will make sure that I can go as low as possible. So sometimes I hold the testicular vessels. Now, the key about holding the testicular vessel and vase is that you have to hold them gently, number one. And second thing, you have to keep the hole very close to your dissection, not more than 2 centimeters away. Because if you are dissecting too far down and you are holding it too far up, you will need a lot of traction and you will need a lot of grasping to keep a hold on it, and they can damage it. So you have to keep your left instrument very close to the dissection. Hold the testicular vessel or the vase very near to where you are dissecting. Otherwise, you will damage them. So again, I will just burn and swipe, burn and swipe. Testicular vessel is giving vascular adhesions to these peritoneal flap. If I just do it bluntly, there will be bleeding. So I'm making dissecting the vase of all the tissue of all the peritoneal adhesions. And I have to keep on doing it till the vase turns medially into the seminal vesicles. Now, we cannot directly see the seminal vesicles here, but we can see it is turning medially. Now, the area where my cautery is right now, this is the dangerous area. This is the area we should fear. Do not go with cautery there. Do not go blindly there. This is the corona mortis area. It's the most lateral part of the pubis bone. It is just medial. It's just inside to the triangle of doom. External iliac vessels are very thin. External iliac vein is very thinly covered here. Since it's a vein, it's not pulsating that much. You cannot see it. And the moment you see it is when you have swiped the fat away from it and the vein is staring right at you. So the movement I usually use here is a blunt one. So this is my blunt movement that I use. I use the shaft of the cautery or any blunt instrument between the pubic bone in the front and the bladder on the back. This is my cleavage plane. I will go in between them. I will make small boring movements, small gentle movements. I will bore my whole OT staff with that. I will make 15 or 20 such movements, slowly, 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 again and again. And the tissue will just separate itself. No need to go with the cautery there. See, these are the movements. I keep on swiping down, 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 keep on swiping. I'm not in a hurry. And here I have just made visible the obturator nerve. This is I will show you the obturator nerve here. So this is on the left side, which I'm holding is the bladder and the peritoneum. On the right side is the pubic bone. And on the rightmost side, there's a vertical bluish thing. This is the external iliac vein. And it's slowly pulsating, so you cannot see it. And I think you can appreciate the obturator nerve here because it's visible. It's a white band on the right lower aspect. So again, I've turned the camera. This is the external iliac vein. You can see it. And my cautery strip is on the vas deferens. Coming from right to left in the anatomy, my cautery strip is on the vas deferens. A bit left to that is the external iliac vein. A bit left to them, these are basically the lymph nodes of the external iliac vein. A bit to the left, the white structure you are seeing, it is obturator nerve. Now, obturator nerve needs to be visible, or at least you can go 2 to 2.5 centimeters below the pubic arch. This dissection needs to be done so that a good flap can be tucked inside the space of Retzius, and there is no chance of recurrence. This is the obturator nerve. You can see this?
Dr. Shehryar. Yes, we can see.
Okay, sir. Most of the times I find that aberrant vein there in vast minority of cases. So there are some cases in which there is a thicker peritoneum. It's difficult to just cut it with the look. You can use a scissor there, or you can just use the tip of the cautery. So in all these hernias, but I've learned this thing that if the hernia is a direct hernia, it doesn't matter. In TAP, everything is the same. It's a sliding hernia. Like you literally forget what a sliding hernia looks like while keep on doing TAP because it does not matter to you anymore. If there is a sliding hernia, calling the TAP, it doesn't matter. You just do the TAP in the same steps. Here I'm showing the space of Retzius being made between the bladder and the anterior abdominal wall. It's very easy to make. Again, we have to keep remembering that we have to push the yellow fat, we sometimes call it the prevesical fat, towards the pubic bone. And we have to make the flap near to the bladder. Do not be afraid of the bladder. So what I was saying that if it is a direct hernia, if it's a indirect hernia, it doesn't matter. It's a sliding hernia. It's all those types of hernia, they don't matter. You just have to do the TAP. And you don't have to change any of the principles, and the results will always be the same. And the mesh will cover all those hernia, whether direct, indirect, femoral, anything. And one more thing, while doing the space of Retzius, we have to completely dissect the whole pubic arch. I mean, if I'm doing a right-sided hernia, I dissect it till I can see the left side of the pubic arch also, so that my mesh can completely fit in. Now, again, these fibers, these are the bad fibers, the fibers on the left side. These are the fibers of the transversalis fascia that keep on pulling your sac away from you, and you have to keep on fighting with them, especially in the starter. In cases you basically hate these fibers, they will keep the sac, they will just pull the sac away from you. So dissecting them earlier helps you. This is a space of Bogras I made on the right side. Now these are the fibers. I have to take these away. Burn and swipe is the key. And you keep on checking where the external iliacs are. The good thing in the TAP is you just have to flip the flap and you can see them. And again, the key is burn and swipe. A very good stretch on the left hand is a must. Now, after that, my next step is to go lateral to the sac and find the testicular vessels. I just make a vertical burn here and just swipe it. I do not use blunt dissection here to avoid the bleeding. I give very small bursts of cautery, and you can see the testicular vessels become they become visible very easily, and then I give swipes. I'm using the heel of the cautery to swipe it. Scissor is a very good instrument, but it's a very large instrument. And what I believe is that if we are going to use the allo for the rest of our lives, so why not here? So when I keep on dissecting the, one more thing I have to show here, I keep on dissecting. This is on the medial side, and this is the dangerous area I was always talking about. This is the corona mortis. You've seen that I make the complete dissection of the hernia, and this is the part that I go in the last. I do not use the cautery here, and I do it in the last when I've dissected everything. When I'm clear of the whole anatomy, then I enter this place. Otherwise, I keep on avoiding it unless I'm clear about the anatomy. So this is the corona mortis area between the bladder peritoneum and the iliacs. On this side, I have dissected the testicular vessels away, and while doing so, I keep on going behind the sac, and I reach the vas deferens. Vas deferens is visible; it's thicker, white, and a bit spirally. The spirally thing is the vas deferentia. The spirally white thing is the vas deferens. So I keep on gently thinning this space, and when I can go across it, I dissect the sac away. I dissect the sac away from the testicular vessel and the vase. Again, buns and swipes, and there's sometimes pseudo sac here. I'm just dissecting the sac away. I'm just cutting the true sac. And about tacking, I do not use tackers. I had a very bad experience with the infection, 3 cases. It happened early in my career, and I have never used a tacker after that. I always suture them, and I use a non-absorbable suture. The best choice would be and an ethibond. Otherwise, proline, silk, anything can be used. My screen is visible, sir?
Excellent.
Dr. Shehryar, we can see.
So I'm using a silk suture. I like silk sutures. They're non-absorbable, and it's easy to knot. This place is a bit difficult to take sutures. And if you are early in a career, use a ethibond or a silk. Don't use a proline. You will keep on fighting with the proline. And you just need one single knot, 2 knots, and it's done. So I use a second stitch on the lateral aspect of the mesh, lateral and upper aspect, lateral and upper corner, and it has to be more than 2 centimeters above the anterior spiralic spine. I always palpate it, and all these sutures, you have seen these sutures are loose sutures. I have not tightened the suture. The last suture was also very loose. I never apply a tight suture. I always apply loose sutures. I always put maximum fat towards the nerve, and the third thing I do, I always take the sutures 2 centimeters above the anterior spiralic spine. And we have seen only 1 or 2 cases of inguinal in last 500 cases. That is less than 0.5% rate. On the right side, I use the backhand needle. On the left side, for the suturing, I use the normal routine needle. Backhand ulti needle, I said nothing else. So another a loose suture. With silk, it's easier. So I'll go quickly from with the last couple of cases. Just I have to show you a couple of things. Now this is a case of a recurrent hernia. The problem with recurrent hernia is sometimes that you put a scope in and you cannot find any hernia. The patient is complaining there is a hernia. You put a scope, there is no hernia. Basically, most of the recurrent hernias are direct hernias, and they are just a little bulge from the inside, and you cannot see the bulge from the scope directly. So the cue for you is that look for the medial umbilical ligament. The medial umbilical ligament will not be prominent in these cases. If it is not prominent, the hernia is there, hernia is beneath the peritoneum. Now, apparently there was no hernia in this case. The patient had the symptoms. I made a mark. I'll just fast forward it towards the hernia in this very case. Now you can see hernia is not visible anywhere, not very prominent, but on the left aspect of my left grasper, there is actually a hernia there. It's a direct hernia of the kind. So while dissecting the space of radius, we come across the hernia. It's on the left side of my cautery shaft. And we have to be very careful about these recurrent hernias because it is very densely attached, but almost always you can do a tap hernia repair. So this is the recurrent hernia. It is a small one, and the small hernia and bladder was going inside, and it used to give him a lot of pain. It was a very small defect. What you have to remember in these hernias about these, just wait a minute. There is a pseudo sac. What you have to remember, there is a pseudo sac, and you have to completely reduce it, and you have to completely reduce your own contents. And sometimes you can even repair it. Now, the cases in which you cannot do a tap are the cases where an open bladder surgery has been done and there was a post-op infection, they are totally no-go. The bladder and the space of hernias, they are completely fibrosed after open bladder surgeries, and it's very difficult to go in. So it's better to use an open Liechtenstein approach. So this was a small hernia. It was a direct hernia, and when that dissected, they're very nicely visible. Yeah, there was a little bit of bleeding, but it can be managed with cautery, or you can just put a gauze, pack it, and then take out the gauze. Do not leave anything there. So this is the space of radius I'm making. So I'll fast forward to the next case. I think we have the last case after that. Now, this was a different case. It was a recurrent hernia. Well, and he had another hernia on the left side, recurrent hernia on the right side. When you found out there were basically two direct hernias on the right side, and there was one hernia, direct hernia on the left side, and there was a femoral hernia. It's a bit bloody video, but I'll show it anyways. So it was a right-sided direct hernia. It was a recurrent after, I think, 1 or 2 surgeries it occurred. So this is pseudosac, very beautifully looking pseudosac is here. You can appreciate it. You can just peel it off. I don't know, the theater staff really enjoys this step, especially the anesthetists.
Left side
no, my instrument, it's on the left side. Now imagine the left side of myopectoral orifice of Fouchard. My instrument is in the femoral hernia right now, and the left iliacs are a bit below where I have marked them, and the pubic arch is in the right upper side of the screen.
Femoral hernia. जब इंस्ट्रूमेंट में डाल रहा हूँ ये hernia के अंदर डाल रहा हूँ बार-बार. ये बड़ी सारी.
This is the triangle of doom. You can see the inverted V.
The iliacs हैं जो बोलते
हैं. Direct sac. There was no direct hernia. So this was this femoral hernia. You can see the big external iliac vessel that turns in, which is named the femoral vessel after it goes through the femoral canal, and just to the middle of it is the hernia. This is the femoral hernia. Now, along with the femoral hernia, so this is a case of. So I'm just giving a review of this hernia patient, showing this video. My aim to show this video is that you have to look for all the hernias. Sometimes you miss them and the patient keeps on complaining about them. Recurrent right-sided hernia के साथ patient आया था. So the patient has both sides. He is having direct hernias. This is a direct hernia on the left side. This is a direct hernia, big direct hernia on the right side. A smaller direct hernia on the left side. Two other hernias on each side. On the right side, he has one big direct hernia, and this is the other big direct hernia. This is the second hernia on the right side. The two hernias on the right side, one direct hernia on the left side, and this is one femoral hernia we just had a view before. So there were 4 hernias in the same patient.
Right side में usually backhand needle में use इस्तेमाल करता हूँ.
So again, I use a backhand needle on the right side when I'm suturing it. I suture it from the, we all say that we suture it from the Cooper ligament. Honestly, after 500 surgeries, I still don't know where exactly is the Cooper's ligament. I just suture it where I can find the thin periosteum. That's all. Cooper ligament is there, but we cannot completely appreciate it. So we find the periosteal bone anywhere, just away from the corona mortis, put a small suture there. But it should not be a thick bite and it should not be a tight suture. I'm using a Prolene here, but again, a loose suture. I will never tighten it. So this is the second. This is the same case of bilateral hernia. We're putting a suture so that both the meshes get tacked with a single suture. Okay, nice. So this is the last case I'm showing for the last few seconds. It's a hernia that we operated It was a large hernia, and he had like 20 feet of gut in it, 15, 6, 17 feet of small bowel, and 3-4 feet of large bowel. And it was a very interesting case. This patient, I had difficulty in fighting with its sac. I had to cut it between. But these patients have a large propensity to get a seroma afterwards. I think we should do the hernia repair from the TAP approach. Thank you, sir. Any questions?
Dr. Shehryar, excellent. Isko na wo kar do, stop sharing.
Let me find where. Stop sharing.
Excellent जी, excellent. वो last जो music था मैंने पहले confirm किया कि मेरी वीडियो वो mute है, तो थोड़े अपने हाथ भी हिला लिए थे आपकी last. Excellent presentation, really. And Dr. Tansir is with us. Dr. Tansir, any comment? Dr. Tansir, please unmute.
Thank you very much. Thank you very much, Dr. Imran. It was a very nice presentation and very nice effort by Dr. Shehryar. And I welcome him formally for doing such nice presentations.
Yes, sir.
And I think it will give motivation to the young surgeons all over Pakistan and our GLR fellows across the globe that they should participate more and more in the academic process of the GLR. I highly welcome Dr. Shehryar, and I'm really proud of his efforts, his surgeries, and his academic vision and his contribution in this. I'm always
Yes, I think there is some connection issue with Dr. Tansir.
can you hear me now?
Yeah, please continue.
Okay, so I don't know till how much you have heard, but I really appreciate all the efforts which is put in by Dr. Shehryar at the level of the Society of District Surgeons, at the level of now GLR, and I really appreciate and I really welcome him in the GLR as an academic person now.
Thank you, Dr. Tansir. We also, Professor Naveed is with us. Professor Naveed, please, any comment? Any question? Professor Naveed, please unmute yourself. Professor Naveed. First, unmute yourself. I think, Professor Naveed, can you hear me? Dr. Adil, please, any comment?
Yes, thank you so much. Dr. Shehryar has always been in the limelight for some years now. He's doing an extraordinary job with his... I've never had the opportunity to meet him in Bhakkar. We've met on a few conferences. He will be with us in Peshawar, inshallah, and he'll be joining us in PSMBS. You'll be welcome, and you've always been so supportive to this academics, and now welcome to the team of GLR. I think there was one little feather in the cap that we needed, and fortunately we have that feather in the cap now. Thank you so much again. And there's one comment that I have to make about some of the techniques that he was showing about the different cases and the variety of cases that he had presented today. And I love this presentation in its own way. Although we are not dealing with slides here, we're having to see videos. Video presentations are, I think, for the level at which we are providing the training for our fellowships, our fellows who are already fellows, they have FCPS or they have other postgraduate qualifications. is that when you talk about the skill set that doctors, the surgeons have today, and there are those variations in technique. I mean, I learned quite a few things today, and they were very unique. I know that there's Dr. Shehryar and his team has a very large volume of hernias as compared to some of our more elite surgeons in the GLR group. For one, the part where he discussed the fibers that withhold the sac and prevent them from a more rigorous dissection, is meaning that, and then the point where he mentioned how he dissects the testicular vessel and the vase with the blunt cautery and trying to separate them, and then knowing when he has released enough of them, and then the part where he follows the testicular vessels right next to the corona mortis, and he gets into that pocket, and he decides the point at which he's going to finish off his dissection. That was very unique, and I've learned a lot from this
Honor, sir.
this presentation today. And I hope you keep doing things like that, and you come up with newer ideas, point out those little things that we're missing. And thank you so much, Dr. Shehryar, for being with us.
It's a great honor, sir.
Yeah, excellent. Really, Dr. Shehryar, this is your demonstration definite. There is no doubt. And your dissection, tissue holding, how you must hold with left hand, this retraction, everything is important. In my opinion, inguinal hernia repair or tap, any technique, this is not basic laparoscopy, advanced, because in tap you have everything. You have dissection, you have also the tissue holding, you have suturing. Till this mesh, in fixing the mesh is not so simple. How you, because when you will have a sufficient space, then you can properly put your mesh and fix your mesh. So any question from our fellows, from our audience, because we can take only 2 questions already. Yes.
Dr. Imran.
Ji, please.
Dr. Waleed here, sir. First of all, congratulations for such a great session. और Dr. Shehryar has presented very well. और काफ़ी सारी चीज़ें माशाल्लाह clear हो गई हैं. I must talk about port positions and how to deal with ergonomics in inguinal hernias. Like, doing inguinal hernia is not an easy job, it's a tiring job. So when you have a lot of volume and you have to do inguinal hernia on every list, so it's necessary to talk about the ergonomics. So Dr. Shehryar, can you please elaborate your port positioning and where you stand?
So first of all, when you are starting the inguinal hernias,
just
Dr. Waleed, I must complete this answer. So because when Shehryar started his presentation, he completely elaborated his patient position, ergonomics, and table position, and also trocar site in details. At least 10 minutes he, because this is the main thing.
Sure.
What is the surgeon position? What is the assistant position? What is the patient position? Yeah. How much patient must be head down, tilt, which degree, and also trocar site.
Yes, sir. We should talk about port positioning, where surgeons should stand, where to start opening flap, and how to close the flap easily, and how to apply sutures on mesh fixation, and where we apply sutures. These are the things like everybody should know about, because these are the things they make you tired in whole procedure.
I can give a very brief review of this.
So Dr. Shehryar, can you please? Okay.
So first of all, patient position, it should be a bit head down so that intestine come back inside. Second thing is that it should be tilted 15 degrees up toward the side of the hernia. The third thing is that you have to strap the patient. So you have to make sure before the strapping that the head of the patient is at the cephalic most part of at the uppermost part of the table, so that when you are standing, the patient's head should be resting against your tummy. It is a must. Otherwise, if the patient is tilted away from, strapped away from you, you have to bend over like this. Like I'm showing, you have to bend over, and you will have a lot of backache after that. Second thing is that in the port positioning, just imagine a hernia. You should be in line with the umbilicus and the hernia. You should stand like that. in front of you should be the umbilicus and the hernia, and the cautery should be under your right foot in the same line. If the cautery pedal is over the right or the left side, you will start developing knee pains. I had those pains, trust me. I used to have the cautery on sometimes left side, the right side. I will twist my knee, and then I started having the knee pain. So first of all, your foot, your hands, your body, your umbilicus, and the hernia, they should be in the same line. And at the end of the line should be your monitor. And the monitor should be a bit low so that you can flex your neck. Your neck should not be extended. It will give you a lot of pain. Your shoulders should not be up like these. They should be drooped down. Your elbow should be extended. It should not be flexed like this. So when I do this, my usually aim is, if it's the right hernia, the port position is like umbilicus. I'll put the camera 2 to 3 centimeters above the umbilicus for a better view. I will always use the angled laparoscope. Although 0 degree can work very well for me also. If it's the right hernia, the right port is 2 centimeters above the umbilicus, the left port is 2 centimeters below the umbilicus. If the hernia is on the left side, it goes the opposite way. The right port becomes 2 centimeters below the umbilicus, left becomes above the umbilicus. And after saying that, about tacking and closure of the mesh, I use sutures. I usually tack it at 2 points, but if it's a big direct hernia, I also tack it on the 3rd point also. The 2 points that I always use is on the Cooper's ligament or the backside of the pubic bone, whichever you call. I use a loose suture, non-absorbable loose suture, and I always take a very thin periosteum. This is the most difficult suture, but it really helps you to develop your skills for doing suturing in the pelvic, deep pelvis. Now, the second suture I take, I make sure it's on the upper lateral aspect, and I make sure it is more than 2 centimeters above the level of anterior sphenoid spine, so that there is no risk of any entrapment. And lastly, it is a thin film of tissue I will take, and I will always keep it very loose. Now, closing the flap, I use a Aberdeen's knot, a preformed Aberdeen's knot. I usually 25 to 20 centimeter suture I use. It's a Vicryl 20 usually, or 30. The preform knot helps me to avoid any knot. It's basically like a V-lock. I started from the lateral side. Always I started from the lateral side because it's most difficult to take a knot on the lateral side, because your port on the lateral side of the hernia, whether it's right or left, it is very close to it, and knotting is very difficult to make a reef knot and stuff. So you need a preform knot of Aberdeen style. You lock it after passing the suture through that, like a V-lock, and you keep on suturing it. After 3 or 4 bites, you keep on pulling, and you pull the thread along the incision of the flap. When you pull the thread along the incision of flap, it falls in line. And when you complete it, I again put a laparoscopic Aberdeen at the end, because when I stretch it, it will close all little gaps in the flap. And we must not take very big, very far off bites, because if the bites are very far off on the flap, it's going to cause big gaps in it, and the gut can go in it. And we had one case, one of our fellows, a very good surgeon, he forgot, in fact, it was not a flap end, he forgot to close the end of the hernia, and the gut went inside. There was an obstruction, and he was very able guy. And before I came to wash up, he put the scope in, and he reduced the hernia, he reduced the gut, and he has sutured it already, and the patient went home. So we have to close the big gaps, but we can leave the very small gaps, because it is hypothesized that they help to decrease the chances of seroma, because they will all the fluid will be absorbed inside the peritoneal cavity.
Thank you, Shehryar. So any question, last question, only one question we can take if any person, any fellow. So my thanks, Dr. Shehryar. This was one of the best session, no doubt, and really tap hernia is difficult, and also demonstration of tap hernia is very difficult, and you demonstrate amazing. So best of wishes for Dr. Shehryar.
Welcome, sir.
From the team in Bakkar. And next week, then we will continue our academia, and this session next week, same time, we will be with Dr. Waleed, and that is also another important topic. And in my opinion, especially for our young fellows, this is most important topic. That is so ergonomics in laparoscopy. That is really very important. So your position ergonomics. That is much difficult topic, and also we selected a gentleman, Dr. Waleed. He can do this. And next week we will. And if you, our fellows, if you have any question, we have a WhatsApp group, Fellows 2023. You can ask in that session. All of these mentors are also part of that group. If you have any query, any question, you can ask and we will answer. So much thanks and have a nice weekend. Thank you.